Good afternoon, everyone. We're going to get started now. Welcome, everyone, to CSIS on this beautiful spring day, and that includes a welcome to those that are joining us online. I'm Steve Morrison, Senior Vice President here at CSIS, and I direct our global health work here. I want to offer special thanks to some colleagues and friends who made this event possible. This is our third experience here in having the opportunity to roll out the annual Financing Global Health report from the Institute for Health Metrics and Evaluation, and we're thrilled to play that role and be able to host the team that's come here today. I want to especially thank Katie Leach-Kemen for her continued support and help in pulling this together. My colleague here at CSIS, Sahil Angelo, played a key role on our side in pulling all of the parts together. Travis Hopkins is here today managing the room. Thank you, Travis. What we're going to do, let me just quickly explain the lineup here today. Professor Joe Dieleman, Assistant Professor at the Institute for Health Metrics and Evaluation at the University of Washington in Seattle, and the lead economist on this report, is going to open things up with about 15 to 20 minutes of summation of what is in the actual Financing Global Health 2015 report, as well as two Lancet pieces and an AIDS piece that are companions to this, very interesting companions this year. We've got a multitude of products coming forth at this moment. And so Joe is going to play that role of laying out what is contained in those various products. And then we're going to move from that point into a roundtable discussion. And so we'll be joined by Chris Murray, the director of IHME. And Chris, we will ask to open up the roundtable with a discussion of what does this mean? What are his reflections on what all of this new analysis tells us about the world that we live in. And then we will move from there to hear from our other roundtable speakers. We're delighted that Jennifer Cates, Senior Vice President at Kaiser Family Foundation and Director of its Global Health Programs, is with us today, known to all of you here for her prodigious work, particularly on analyses of budgetary issues spanning the entire spectrum of U.S. global health programs. We're also joined by Jeff Sturchio, President and CEO of Rabin Martin, also familiar to all of you as a leader in this field, a very distinguished career, starting in academics, leading into a 20-year career with Merck, head of Global Health Council, and now President and CEO of Rabin Martin. And a senior fellow here at CSIS in our Global Health Program. So we are going to move briskly through that portion, those two portions, with the hope that we can bring back the opportunity to all of you to weigh in with comments and questions at the earliest moment possible. We really want this to be very interactive with you. So with that, thank you for all coming today. Congratulations to IHME, to Katie, to Chris, to Joe, for this really impressive and terribly important and terribly timely work that you've brought forward. And thanks so much for coming from Seattle to be with us today. So Joe, over to you.
Cool. Thanks so much. Thanks everybody for being here. It's great to work on this research year-round and kind of fall in love with this work, and then to be able to come here year after year and kind of share the work in this space with many of you. It's very gratifying and exciting. Thanks so much for giving up part of your day to be here. I'm going to be presenting our Financing Global Health 2015 research. And before I go too much further, I need to thank a couple of people back in Seattle who aren't here today, but who really made this work possible. Those are people who did data extraction for hours and hours on end. Those are people who write numerous lines of computer code to make it all come together. People who have built the website that I'll be showing off. So thank you to all of them, and thanks particularly to Lavanya, to Max, Alex, Nafis, and Tara, some of our analysts that have spent countless hours to make what we're looking at today all come together. So what I'm going to be presenting today is the seventh in a series of annual reports that IHME has put together focusing on development assistance. So each year we call this our Financing Global Health Research. This is the 2015 version. The first came out in 2009. And the primary focus of this report each year is to track development assistance for health. And what that means to us is we're looking at the financial and in-kind contributions that come mostly from high-income countries, go to low and middle-income countries with the primary purpose of maintaining and improving health. So that doesn't include water and sanitation, it doesn't include other allied sectors, but it does include the main kind of actors, agencies, and organizations that I think many of us think of when we think of the international component to global health research. The report also tracks government health expenditure. That's the domestic share that's raised and spent by the government. I'm not going to speak as much about that today and focus mostly on the development assistance side, because that's mostly what the report is most known for and what we focus on. In addition to the report that's coming out today, we have an interactive visualization, which I'll highlight in a couple minutes. We also have a data release for people that do their own analysis or are interested in diving deeper in a sub-analysis that's not completed in the report. We encourage you to check those out. In addition to those three things, we have 3 academic peer-reviewed papers that are coming out today. And I think we really value the back and forth with peer reviewers and through the academic process to really ensure that what I'm presenting today is founded in good science and the best methods and data available. So this year we have 2 papers being published by the Lancet. Those are available as of today. And 1 paper being put out by the AIDS Journal, which is also available online today. And I'll be kind of presenting this material throughout the talk, but a real quick summary is that the first paper listed up there, titled Development Assistance for Health, takes a real in-depth look at development assistance from 1990 through 2015. And what's new in this report is a more systematic accounting of these methods. Every year we kind of take one step further in improving the data that we collect and how we put them together. In addition, we've done a statistical analysis where we look at different points in time and look for these structural breaks. And most importantly, we've noticed and detail in the paper that these statistical shifts that have taken place across time. So there's a shift in 2000, there's a shift in 2010, and I'll talk more and show you those, actually what I mean by the shift. The next paper that I'm going to discuss towards the end of the presentation is work that we've done that expands beyond development assistance for health and focuses on total health expenditure, and then within that, 4 different main pieces, and thinks about future estimates. So the main purpose of that research is to use past trends and relationships to say, okay, if these things continue, what do we expect the future to look like? And that works with 184 countries, essentially a majority of the world, and makes estimates through 2040. And the last piece of research that I'm going to talk about today has been published in the AIDS Journal, and that takes a deep dive into development assistance for health that is for the HIV epidemic. And so it focuses specifically on, in 2015, the $10.8 billion of development assistance that is targeting HIV, and tries to ask what questions can we learn specifically at maybe a more granular level about those resources. So I hope that this screen is something that many of you are familiar with. This is what we call a flows diagram. And this is, if you go to our interactive visualization, which I'm going to try to do now. There we go. So this looks, it's the same thing as the slide you were just looking at. The idea is this is an interactive visualization that I hope many of you have already seen. And it's new and improved. So I'll kind of take you through how it's changed since last time we were in this room giving this presentation. But the key idea of this flows diagram is that this is a snapshot of development assistance for health in 2015. So let's see, here's the pointer. So you can see down here, this is customizable. I'm going to focus on our most recent estimates, which are for 2015. And in 2015, we estimate that there was $36.4 billion of development assistance. So each one of these columns essentially represents that total amount. And the three columns here are the sources of development assistance, the intermediary channels, these are the agencies that are actually dispersing the development assistance, and then on the far right here is the health focus areas. This is what the resources are targeted. So each one of these columns adds up to $36.4 billion, and you can see then how the flows go from the source to the channel to the health focus area. So starting over here on the left, the sources, I think some of the interesting stories or the kind of takeaways from this year's research is that there's a number of sources that have continued to kind of buoy in the amount that is available of development assistance. The United States stands out. The United States as a source of development assistance, that's essentially money coming from the Treasury, has increased by about 4% from 2014. And so the total you can see is $13 billion, or about 36% of all development assistance for health that we're able to track. Other increasers are the Bill and Melinda Gates Foundation, went up by about 10% from 2014 to 2015 and gave a total, or provided a total of $2.9 billion of resources. And down here, the UK also was a major grower, increasing at about 4%. And providing a total of $4.1 billion of development assistance. So I hope you can see that essentially the size of the bar is proportional to the amount of resources that they provided. If we move over to channels, you can see that the United States is, of course, a source in the sense money is coming from the U.S. Treasury going towards development assistance. But then the United States is also a channel in the sense that there's U.S. agencies that are dispersing that development assistance. You can see a lot of U.S. money comes from, goes to private NGOs that are dispersing that development assistance. And you can also see that the United States funds some of the other channels, such as the Global Fund, the UN agencies and whatnot. One of the new components of our visualization is that it's very hierarchical. So this flows diagram can be zoomed in upon. So this here is a look at the UN agencies, and you can see what sources are providing, the NGOs. You can see which sources are providing the NGOs, and you can see where those resources are going. So if you're particularly interested in that sector, you can kind of take a deeper dive to understand what's happening. If you switch down here to the UN agencies, you can click in as well, and you can see now that it's disaggregated across the different UN agencies that we're able to track. So you see PAHO stands out, UNFPA, UNICEF, UNAIDS, and the WHO. And again, by looking at it this way, you can see the sources that are providing resources for those channels, and you can see which health focus areas they're going to. New this year that I mentioned before is that we can dive deeper into understanding where resources are going on the HIV front. So we see in 2015 that $11 billion, that's rounded up, it's $10.8 billion of development assistance, was provided to the health focus area that we think of HIV/AIDS. But if you dive deeper and you click, you can see that these are the subcategories, the program areas within the health focus area. So all of these are specifically focused on HIV/AIDS, but you can see that it's resources that are going to strengthen the broader health system, they're going to treatment, they're going to prevention. And so you can see in 2015 that those three categories really make up the major pieces of HIV funding, with treatment receiving $2.7 billion, and then health system strengthening each receiving about, and prevention each receiving about $2 billion. And just to point out that this is dynamic, if you're interested in going back in time, say we go back to, say, 2000, all of this will shift, and you can see how there's major changes in what was being provided. Prevention was the main piece of program area support within HIV, and you can see as you go further back in time, there's more and more resources that we're not exactly sure how they were dispersed. The other way to analyze this data is to think about it across time. So now you see in this stacked bar chart across the x-axis is time, and you can see that there's essentially 3 epochs or 3 eras that we've described before, and we go through and do a little bit more statistical analysis this year in the first of the 2 Lancet papers to assess how those trends have changed. So in the 1990s, you see that there was essentially just below 5% annual growth. That's the average annual growth across that 10-year period, and generally you saw these increases. As soon as you switch from 2000 or 2010, there's 11% growth. So the growth rate, essentially the trajectory of how much development assistance for health is being dispersed in total, increased drastically during this period from 2000 to 2010. Starting in 2010, we actually see this major slowdown in the amount of development assistance being provided. And if you go from 2010 to 2015, we see 1% annual growth. So this is a really major shift, something that's been documented in our past reports as well, but something we call additional attention to. I think as more and more data comes out, it becomes increasingly clear that the era from 2000 to 2010 was in fact a unique period, at least relative to the last 5 years. Just to point out a couple more capabilities of this figure, if you're interested in thinking about the composition of these channels, you can also look at it as a percentage. So I think what's interesting about this figure is that these blues and purples are essentially the bilateral aid agencies. So right now we're looking at the channels of development assistance. And all these blues and purples are different bilateral aid agencies. The yellows up here are the UN agencies that we're able to track. And if you go back to 1990, you see that 84% of all development assistance was from bilateral aid agencies or UN agencies. If you fast forward now to 2015, of course, the colors stay the same, and you see that a significantly smaller share of development assistance is being provided by those same channels. So now, instead of 84% being provided by bilateral aid agencies and UN agencies, we see that's 45%. And of course, this makes space for some of the new actors that have been providing a lot of development assistance. We see that Gavi makes up 5%. The Global Fund makes up 9%, the Bill and Melinda Gates Foundation 5%. And we see that that the NGOs, while of course those have existed throughout the study period, have really increased the amount of development assistance that they're dispersing. The last thing, just to point out some more capability, is this can be looked at for the regions, where's the resources going to, and then also for the health focus areas. So now this tracks those major areas, and we see, of course, on the bottom here, HIV/AIDS receives the largest share of development assistance for health, and in 2015, we estimate that 30% of all development assistance was going towards HIV/AIDS. One last thing to point out is this is very customizable. So if you're interested, for example, in a specific source, so I click here, source, and you're interested in the US government, for example, you can scroll down here to the bottom, and now we can see the health focus areas that the US government is investing in. So this is the US as a source, not the US agencies, but think about the US Treasury. And now we can see that of all the development assistance that the US government offers, we see that about 57% of it is going to HIV/AIDS. And just to point out again, different capabilities here, we can also look here at the percent change. So this is looking at change from 2004 to 2015. Again, I still have it set, so this is just development assistance from the United States. And we can see the major increases during that time period is malaria, maternal child health, tuberculosis, and HIV/AIDS. And of course, again, very customizable. So if you're interested in these most recent 5 years during the time of tepid growth, we can see that the United States is actually providing more resources for health system support, and while there's still increases in some of the major health focus areas of the previous decade. The last screen, just real quick to point out that it's available, maps where the development assistance is going. So what we see here is just the total amount of development assistance that's received by each color. The brighter the red, the more development assistance that was received. You can see that this goes through 2013, and because of data limitations, we're not able to take it any further. So we see that Nigeria received the most in 2013. And I think one important thing to think about is you can think about the amount of development assistance received relative to a number of other different contextual variables. So one that we focus on a lot is disability-adjusted life years. Disability-adjusted life years are, of course, just a metric that measures the burden, the health burden within a country. So if we click on that, now we see that we're essentially looking at the fraction of development assistance for health per DALY, per disability-adjusted life year. And you can see Nigeria is, of course, now not the largest, and that's because of a large health burden, a large population. I'm going to switch back to the slides. And this is the last figure that falls directly related to development assistance, and I think it's a figure that's hard to show on the interactive visualization. So I just pasted it here. It's in the report, and it's also, we have a 2-page policy brief that I hope some of you have picked up. It's on there as well. What this figure does nicely is it juxtaposes the 2 time periods that I mentioned before. There's this golden age of 2000 to 2010, which is shown in the dark blue bars, and you can see the annualized growth rate during that 10-year period. In the green, you see the 5-year annualized growth rate from 2010 to 2015. So what are the takeaways? Well, you can see that 2000 to 2010, the bright blue, especially for HIV, malaria, and tuberculosis, were growing at a tremendous rate. And so this here, just to put it in context, when you have a growth rate above 20% annually, you're talking about doubling essentially every 3.5 years. So amazing growth for those health focus areas. You can see that all the health focus areas are growing during that period, but HIV, TB, and malaria are growing especially fast. It's important to juxtapose that, I think, with the most recent 5 years where you see the green bars are much attenuated. And we have HIV/AIDS growth rate for that health focus area of closer to 1.2%. So recall I said there was a doubling every 3.5 years before. With the new growth rate, we're talking about a doubling every 60 years. So a very different trajectory moving forward for some of these health focus areas. And I think it's also worth pointing out that while HIV, malaria, and TB, the growth rates have not been sustained, the growth rates for child health and maternal health, while always less than those other 3 communicable diseases, have been sustained a little bit more and are some of the highest growth rates that we're seeing between this period. All of that change and uncertainty revolving around how things have changed and moved forward over the last decade and a half has led us to invest a lot of energy and time into thinking, what is the future going to look like? So this now turns to that second Lancet paper that I referenced at the beginning, where we're looking at 184 countries using past trends and relationships to just derive some scenarios that ask the question, if these things continue, what's our best guess on what's going to happen? So this is not a crystal ball. It's not a guarantee of what's going to happen, but it is our way of saying, without major change, all of the covariates, all of the relationships that we can model, this is about what we think is going to happen. And so you can see right here, I have 3 different sources of total health expenditure. So on the left, you can see government health spending, and this figure here is looking specifically at low-income countries and measured in per-person terms. And for government health spending between 2013 and 2040, we estimate about a 4% annual growth, so going up. For prepaid private health spending, that's essentially private insurance, we actually estimate a 5% growth rate. So this is really across all the countries, we tend to forecast a growth rate in prepaid private insurance that's going up faster than most of the other types. And the last one is out-of-pocket spending. So this is private spending that's not insured, not prepaid, and we see a growth rate that's more like 2%. So again, all going up, I think tends to paint a positive picture. And then we also do scenarios to estimate what we think development assistance is going to look like from 2015 to 2040. And I think the most important thing to recognize here is how challenging estimating development assistance in the future actually is. And that's why you see these very large uncertainty intervals. It's very hard to determine if that golden age that I've already mentioned several times between 2000 and 2010, is that an anomaly? Was that a one-off? And if so, then we expect to see a very attenuated growth rate relative to that decade. On the other hand, is it possible that that would be repeated? And I think there's reason to assume that could happen as well. So you see essentially a very large uncertainty interval, and our mean estimate, our best estimate, is an annual growth rate of about 1.1%. Going back to the figure that I first showed you, it's important to recognize the y-axis on these terms is in per capita spending, and this is low-income countries. And I just want to draw attention to the y-axis and how small it is. I think some of this research has pointed to some very sobering conclusions based simply on past trends and relationships. I think it's very easy to assume that with economic development is going to come substantially more spending in low-income countries. And our scenarios at this point say, yes, there are going to be increases, but they also paint a picture that says, when we talk about prepaid insurance, we're still talking about $10 per person on average across all the low-income countries. And government spending, we're capping out right around $50 per person when we aggregate all the low-income countries together. So again, I think reason for optimism with growth, and at the same time, some very clear, important messages to take away about how much spending we think might actually be there. This is another way looking at that. The pie graphs here are total health expenditure broken up by income group across the 184 countries that we're looking at, and the total population of those 184 countries. So what I'd like to draw your attention to is the red sliver. In 2015, there was $8.4 trillion spent globally on health, and despite 12% of the population living in low-income countries, 1% of the health spending took place in those countries. Holding that classification constant at the 215 levels, if you go forward to 2040, we expect many, many more resources available for health, but reality is our models suggest that only 1% will still be in the low-income countries. And that population will have actually grown. Those countries that are low-income now have 12% of the population, and we expect them to have 16% of the population by the time you fast forward to 2040. This now takes the analysis and looks at it by country. I think this is maybe what I was suggesting before. You see continued growth globally, especially high values in Western Europe, North America, Australia, and Japan, with spending above $5,000 per person in many of those countries. And in low-income countries in sub-Saharan Africa in particular, you see very low estimates of total spend per person. Anything that's dark red there is spending that's less than $108 per person, and that's purchasing power parity adjusted and inflation adjusted as well. So. People often ask, as we've given kind of preliminary talks on our findings, well, how much is the right amount to spend on health? And of course, that is a question that we're not at this time capable of answering. I think there's lots of strong opinions on how much should be spent on health. What we did instead of estimating exactly how much should be spent on health is we utilized some existing benchmarks from the Chatham House. So we took 3 benchmarks out of research that they had previously conducted, and we just asked, in 2040, do we expect each of the countries to reach that benchmark? So I'll draw your attention to the low-income countries and lower middle-income countries on the bottom. If you think about benchmark 2, which focuses on $86 spent per person by the government on health, we estimate that about 44% of the low and lower middle-income countries will not reach that benchmark. And if you look at the third benchmark, which says spending 5% government spending of the GDP on health, you can see that we estimate that only 17% of the low and lower middle-income countries will reach that. So in conclusion, a couple important takeaways. The first relates simply to development assistance for health, and what we see is an ongoing stagnation. In 2015, our preliminary estimates are that $36.4 billion of development assistance were dispersed. Despite that stagnation, relatively little growth, there's been lots of transition within the envelope, within that total amount. We've seen changes across the sources that are being provided, the channels that are dispersing the development assistance, and the health focus areas that are being targeted by the development assistance. Because of this stagnation, we think it's especially important to continue to dive deeper into really trying to understand health financing. I think one example of that sort of research is the work we've done here on HIV/AIDS, taking what was one category and splitting apart into 9 subcategories. I think future work needs to take this one step further and start asking questions on how government health spending is being aggregated and how it's being spent across different programs and different populations as well. Moving on to number 4, I think our future analysis says that past trends and relationships suggest that there's growth almost across the board, that spending will continue to grow up, but I think it also hints that, that there's a need for increased investment in particular low-income countries, where our estimates are that spending will remain quite low. And finally, to end on a slightly more optimistic note, it's important to recognize that across all of our scenarios, there's a great deal of variation. That's in the observed data. Currently, there are some countries that spend much more on health than others, even at roughly the same income level. So it's to say that there is, especially in the long run, substantial potential to increase some of the spending here. I don't want to, again, kind of imply that there's some sort of crystal ball that we're looking into. And I think ending on a positive note to say that I think there is, at least in the long run, ample space to increase spending, especially in those countries most in need. So, with that, I'll thank the big team in Seattle, in addition to our colleagues at the World Bank. So.
Turbulent and troubled and uncertain period right now. We're not sure what the Republican Party is going to look like. We're not sure if America can remain committed to external engagement as a top line priority. We know that we've got the SDGs rolling out with a much more competitive, flatter, broader menu of investment options. We're not sure what that means. We know that climate change is coming to the cash register very quickly. And we know that the refugee and internally displaced crisis, born of Middle East crises in North Africa and elsewhere, carries a monstrously high price tag and is burgeoning as we speak right now. So looking at the golden era, looking at the flat line of the last 5 years and trying to make sense, where is this moving? Will we continue to have a strong bipartisan consensus? Where will we see growth? How will we rationalize growth? Is there a convergence or is there deeper differentiation between Africa and the rest of the developing world? All of these questions are coming forward fast and furious, and I think the value here of the analyses that Chris and Joe have undertaken is that you give us some very objective markers for starting to think quite systematically, quite realistically, and in a very sober and informed way. And so thank you, Chris and Joe and Katie, for this prodigious amount of work that you've continued to provide us, which is really unrivaled in terms of the tools that you provide us. You own this field now, for better or for worse. So what I'd like to do now is ask Chris to kick off the discussion of where do you think we really are heading, and what sense do you make of all of this new data and new analysis that you've generated? Thank you.
Thank you very much, Stephen. Thank you for those kind words about our work in this space. I'd like to pick up on some of the clear themes in what Joe said and mix that with the SDGs and make 4 reflections on that. First, we're all aware from the analysis of sort of flatline development assistance for health, or 1% growth. Joe put a nice spin on it, but I would like to reframe what he said about government health spending in low and lower middle income countries slightly differently. That is to say that while we expect, because of income growth, spending to go up, it's not going to go up any faster than income. In other words, the share of GDP based on past trends in low and middle income countries is not increasing. So yes, spend goes up as countries get richer, But this view of the inevitability of increasing shares of GDP going to health, and that there would be a narrowing of the health spending gap because of that, hasn't been occurring in the last 15, 20 years. And of course, the models just pick that up and project that into the future. So that's a very different view of the future than of going from 2% of GDP to 6 or 7% over a generation. Then take the success of the MDGs, the expansion of scope of the SDGs, and particularly for some targets, for maternal and child health, for some of the more ambitious targets around HIV and TB, et cetera, you now have absolute targets, these convergence-based constructs where we want the worst off to reach benchmarks, 70 for the maternal mortality rate, 25 for under 5 death rates, et cetera. So anybody's costing, and we have some, others will have some, is going to show in those countries that are low income and currently far from those targets, there's a huge financing gap that is not going to be filled on current trajectories. And it's not going to be filled by increased development assistance for health unless we can persuade Congress and other key funders that the success and investments during the golden era can happen again. So what do we do about that enormous gap? And that's what I've been thinking some of these implications are. And I just make 4 observations about that and leave them there. First is I think those absolute targets will drive the global health community to pay more attention to the worst off, the poorest countries with the farthest distance to go and the least means of their own. And that's a very different drive than we've seen in an era of relative targets, where investing in everybody was important to achieve goals that were set in percentage terms. The second reflection there is that there will automatically, and we'll have tomorrow at the side meetings on universal health coverage for the spring meetings at the bank, a whole day about how you finance health systems in the future and the whole issue around fiscal space and efficiency. And I think there will be a lot more focus on that. And in order to have that be anything other than speculation, we need a big jump in the quality of data about how governments spend money on what and for whom. And we've seen a tremendous improvement in health outcome data through lots of people's efforts. We've got pretty decent data on the international flows, but we have really poor data on what governments spend them of their own on different diseases or programs or sub-communities within their populations. And I don't think a fiscal space efficiency discussion is going to work unless we get a big improvement in data. I think a third reflection there is there's real value in showcasing where the investments in the MDGs succeeded, malaria, HIV, child mortality, the sort of returns that people got for that, and to not give up on lobbying for more development assistance because there are successful models in the past and we can replicate those in the future. And I think the uncertainty in Joe's forecast for development assistance speak to the importance of keeping that agenda going, of arguing for more development assistance. And I know CSIS is playing a role in that, as many others will. I think the last reflection there is that we should not forget about investments in the allied sectors of education, some of the other contributing factors, women's empowerment, water and sanitation, that we know have huge effects on health. And if we think of the totality of achieving the health-related SDGs, we need to keep an eye on those. And I think we need, again, better data and information to track what happens in those sectors, because that may be super important for achieving these ambitious targets given the sort of financing picture that we're seeing here. So,
thanks, Chris. Jen Cates.
Thanks, Steve and Chris. I appreciate the opportunity to continue this conversation again, like we've been having for a few years. And of course, to be able to speak about your amazing data, which is the best that's out there. So thank you. I want to make 3 points, and Chris and I did not coordinate on this. The first is a comment about the overall trend that they find. The second is the question of the reliance and focus on domestic financing and fiscal space. And the third is on the who, the people that we're trying to reach. So on the first trend, the latest report confirms, I think, what a lot of us have been seeing, and it shouldn't be a surprise that flattening of donor assistance is there. That's not a surprise. It's a trend that's been occurring. I think even if the economic crisis had not hit as hard as it did, it's hard to imagine that we would have sustained the rate of increase that we saw earlier anyway. It just might not have flattened so quickly. So if we think about it from that perspective, it's been kind of a success that we are still at this flat point. And one of the points that you raise in your report that I think is worth highlighting is that it's not just that health assistance increased so significantly, it's a priority within ODA. So it's the largest, for the US in particular, it's the largest part of ODA that donors are prioritizing. In fact, the US puts more to health as part of its ODA than any other government donor. So it's really an area that donors have seen as a key priority in development, and that's thanks to the hard work of researchers, advocates, and champions, political champions who've seen the data and said, we have to invest in the future and in the health of people and communities, or we will not have better development in this world. So it's really a success. And you can see the data resulting from that with drops in child mortality, increases in people with HIV on treatment. I mean, there's a real correlation there, and it's one of the great examples where we can talk about that. I think the challenge that we've come up against is the reality that the future will be different. The future of what this picture looks like will be different. We have a greater awareness of the health challenges. We do have better data. We have quite an array of interventions and tools. We know a lot more about what to do and how to do it. It's just not going to be the donors, per se, that are going to be able to push, at least with money alone, and make the difference. And this goes to the domestic financing side. And I'm less optimistic than Joe and more on where Chris is. I think there's a consensus that domestic financing is going to increase, it should increase, it will increase, and will be a lot more about what the future of financing for health will look like. Countries themselves want to provide more, at least they've said that, and some are. And as the report shows, financing through domestic public resources is a greater share than ODA. So it is already providing more of the health response. And certainly if you look at the projected changes in country income, it implies that more and more countries are going to be growing in terms of income, in terms of their budgets generally, and hopefully they'll channel a greater share of their budgets towards health. But I worry that there's almost too much optimism put in that scenario. And I'm going to use one example. The recent UNAIDS Fast Track update that just came out last week, which had really important findings in it and calls to action, including the importance of front-loading investments now to save money and lives later. It relies on fairly optimistic assumptions of domestic financing that will be available to meet those targets. For example, it assumes that lower middle income countries will increase domestic public sources as a share of their HIV response from 22 to 45% by 2020. That may happen. I think that's fairly optimistic. And I worry that some of the conversation around domestic resources is very optimistic. And the IHME report and the accompanying analysis in the Lancet provide what I think is a more sobering reality about this. And as it shows, and I encourage everyone to look at that report, because when I started to read the Lancet piece, I really found a lot more detail on what the challenges are. While per capita spending will grow in all countries, the speed and the magnitude of those changes really vary. And the Lancet analysis finds that there's no increasing evidence of parity. There's still going to be a huge disparity between low-income countries and higher income and lower middle income. And most of the countries, as Joe said, will not meet even more modest international targets for health spending, let alone Abuja targets or other ones. So it's not a totally optimistic picture. And this uncertainty is based on future trends looking like past ones, which is noted. And as a side note, I don't know if people looked at the IMF's release yesterday from the World Economic Outlook report, which found, and I'm going to quote, that while global growth continues, it does so at an increasingly disappointing pace that leaves the world economy more exposed to negative risks, and the IMF's projections are less optimistic over time. So it's really a future that's not certain. And one other point, that these averages around country changes and income changes are averages. and they belie differences within a country or by income or within groups. So how to address it? I think a little bit more realism is needed. Increasing domestic spending can be accomplished through a combination of favorable economic factors, which we don't know will occur or what rate they'll occur, and policy choices and political will. There will be a role for donors to play in this regard, not just financially, but also through their diplomacy and partnership. And I would also encourage people to look at the accompanying commentary in the Lancet by Tim Evans and Ariel Pablos Mendez, which looks at some of these tools that can be employed to make domestic financing be as good as it can be. But of course, at the end of the day, tax bases have to grow, and governments have to decide to spend, if there is more revenue, to spend more of that on health. And this is not a certainty in every country. And even if a government were to choose to spend more on health, it's not a certainty that it would spend more on all within its country. So that brings me to the last point about the WHO. And are people who need the services the most going to get them? Women, girls, key populations. And I think this is probably our most serious and challenging question. As donor financing flattens and may recede in some years, will these groups be prioritized? And if domestic governments do channel a greater share of their financing to health, will they do so for these groups? And I think the evidence out there is mixed. Certainly for key populations, that's not the case. And if they do not, can we really call this kind of future a success? To me, this is the fundamental question for the future of global health. One specific comment on some of the findings around women and girls and maternal health, which I think are interesting. It's only recently that maternal health has been prioritized by donors. If you look at the IHME report in the back, in 2004, the amount spent on maternal health was less than what was spent in 1994. So it was not, it fluctuated, it was relatively low. It only started to pick up, I'd say, by around 2007, 2008, and it's still a lot lower than several other sectors. And it actually declined between 14 and 15. So it's an area that donors have started to prioritize, but it's certainly not one that's gotten the kind of attention needed, and we can see that in maternal mortality data. And certainly family planning funding is a part of that, which has increased in recent years, but those increases have come even more recently than broader increases on maternal health. I just want to flag a couple things. In the next week or so, we'll be releasing some new polling data that will show, among other things, very high levels of public support among the U.S. public for prioritizing women and girls in development. And we'll also be looking at the U.S. role in funding maternal and child health, family planning, and nutrition, which also shows the U.S. has more recently prioritized these areas, but there's still some dips here and there. And then lastly, just one word on the current budget request that's out by the president. His last budget request as president, fiscal year 17, and it's the first time in several years that the request that he's made for global health is greater than the amount that was enacted last year. So there is a sense that there's a little bit more priority being put on global health. The areas that would increase if the budget is approved would be family planning, maternal and child health, and malaria. The areas that would see decreases are TB, nutrition, and NTDs, and flat for everything else, HIV, the Global Fund, Global Health Security. If the budget as proposed is approved, it would be the highest amount for global health to date in fiscal year 17. So it's still not, it's a tiny increase, but it's a slight increase. I'll end there and look forward to the discussion with all of you.
Thank you very much. Jeff Sturchio.
Thanks. Well, I'm reminded as we've been having this discussion of the observation of that great political philosopher Yogi Berra that prediction is difficult, especially about the future. So take with a grain of salt what I'm about to say. I agree with virtually everything my colleagues have said already, so I'm not going to repeat all of the observations they've made. But let me try and focus on a couple of issues that haven't been raised so far. I mean, it's clear, and I certainly agree, that the days of rapid increases in DAH budgets for health, or DAH, is over for the foreseeable future. And there has been, as Jen pointed out, there's been a lot of attention now to domestic resource mobilization in the hope that with economic growth that will fill in the gaps. But I think that Chris and Joe's data and the work that their team has done demonstrate that it may be magical thinking to think that domestic resource mobilization is going to fill those gaps. And so the challenge that we really face as a community, if we're going to be able to address the unanswered questions and the gaps that are there, is really to find where are we going to find more resources. And it might be useful to just think about some relative numbers. Overall development assistance is about $135 billion, and we saw that health is $36 billion. Foreign direct investment around the world is about $800 billion, and remittances are around $400 billion. So I think one of the points I just want to leave you with is that we should be thinking about where is the money in the world that could conceivably be reallocated to fill the gap in global health. And then there's the simple question, Chris and I were talking about this a little bit before the meeting, how do you actually affect that reallocation? So that's not a trivial task. But the money's there, it's just a question of it's not distributed in the right way. And following on from that, one of the arguments that I think we would have to make to persuade people to reallocate other resources toward health is to really focus more on the efficiency of the efforts we're making, where are we getting the best results, and really taking what we know about what works and turning that into decision tools that can help both program managers and policymakers who have to decide which buckets get filled for what, that there is evidence that money invested in health is actually earning a return that actually is useful not just in health but in other areas. And I wanted to just pick up the point that Chris made about the Sustainable Development Goals and just suggest something we may want to come back to in discussion either today or later. But we have a tendency, because we're all advocates for more global health activity, we tend to think in terms of making the case just in terms of health. But the Sustainable Development Goals, which Ban Ki-moon likes to call the Declaration of Interdependence, are beginning to be seen more as a set of interacting networks of issues that will lead to improvements across the board. So, and the example you use, Chris, is that if we look at health and education and women's empowerment and investment in girls together, it may be that we can get a larger envelope to work on those together, and investments in those areas will have an impact across the entire spectrum of activities, including health, as well as in other areas of the SDGs. So it's just a suggestion that we rethink the basis for our advocacy and start thinking more holistically about how we can approach health as part of this broader set of SDGs. The other point that I want to just also align myself with Jen's remark about, are we meeting the people who have the greatest need? Because if it isn't possible to persuade governments to invest more in health, if it isn't possible to find other sources of revenue or money to work on health, it's going to be women and children in remote areas who have the worst health outcomes, who will continue to be hard hit. It's going to be conflict zones, humanitarian settings, the issues that Steve alluded to, where we're just not going to get the kind of health outcomes that we would like to see, and those will become, it will perpetuate those problems rather than coming up with solutions. And the third general point I wanted to make is that as we think more broadly about efficient use of a broader set of resources, we should start thinking about integration not just in this broad sense I was talking about with the SDGs, but also in the programmatic sense. Governments will get quicker, more efficient, and more sustained results on women and, or maternal and child health, for instance, if there's integration with other areas of health and development. And we've already begun to see this in some of the work that PEPFAR is doing on HIV/AIDS and MCH. We've begun to see it in integration in primary care with interventions for malaria and HIV, as well as some non-communicable diseases. We begin to see that in immunization, nutrition, family planning, and maternal and child health services coming together. And I think that we have to see more of that over time, because particularly if there's going to be pressure on the budgets for health, the best way to get the kind of results we would like to see is to make sure that we're getting the most bang for the buck on the money that's there. And then finally, just to come back to this last point that I made about, or actually it was the first point I made, I'll come back to it, that we need to just start thinking more broadly about where is there money that can be invested in the health outcomes we'd like to see. And one of the charts that I haven't had time to digest all of the work in this report that Chris and Joe and their team have come up with, but I was intrigued by one of the charts on the, it looked at the 20 to 2015 and where DAH has been going in terms of channel of disbursement. And if you look at that, you find that now, and the precise numbers are in the report. But in 2000, the amount of money dispersed through public-private partnerships was negligible. And now it's up to about 15% of all of the development assistance for health. So the engagement of the private sector in partnerships that are actually delivering the services and the products that people need has become substantial. And I think that that's something that we really need to think about much more systematically. Because in many of the discussions that I've had with people at the country level, and I'm sure many of you have had this too, people act as though the envelope of funding is only that money that's available from bilateral, multilateral donors and national governments. But in fact, in many countries, and in more countries every day, there's a substantial investment in private health care. And the private sector is at every level, in health insurance, in the products and services that multinational companies make available at the country level, in the work that national companies do in providing healthcare services, private providers. There's just a very complex pattern of private healthcare provision in most lower and middle income countries. And in most of the discussions around development assistance for health, it's as if this didn't exist. So I think in the future, we're going to have to find more ways to draw on the private sector. Obviously, it's got to be done in a way that's consistent with the goals that the global community has. But as you can see already, it's now roughly 15% of disbursement is through public-private partnerships. And I think that's just the tip of the iceberg. So I'll leave it at that. I'd be glad to talk more about that if people have comments about it. But I want to thank Steve for inviting me to take part in this discussion, and Chris and the team for what's always a provocative sort of data geek's dream of a report that really does illuminate these challenges and give us really interesting new ways to look at the issues. Thank you.
Thanks, Jeff, and thanks, Jennifer. I'd like to ask Chris for any responses to the issues that they've raised, and then I'd like to open the floor to you all and ask you to just put your hand up. There's microphones. We'll bundle up 4 or 5 quick comments or questions at a time. But Chris, what would you like to say in response to some of what we've heard from Jennifer and Jeff?
Oh, just I agree with pretty much everything that they both said. And I think there's as the sort of sophistication of the sort of detailed analysis and the sort of questions that are being raised, I think that means we need to go farther in terms of the detail that we're able to track and look at to help people answer those questions.
I mean, across all of your remarks, you seem, and the report itself implicitly is sort of arguing that we need a new strategy. We need a strategy that's much more refined to the uncertainties that we face, and one that works off of this notion of flatness and of low-income countries unable to sort of make the convergent turn that people had predicted. It's sort of recalibration of some of the basic assumptions that we've carried around for the last several years, and to rethink the private sector. And I really liked what Jeff was saying about reallocation, broader set of interest, integration. I mean, and that resonated very closely with what Jennifer was suggesting as well, I think. There's quite a bit there about the rethink that needs to happen now. I think you've pushed us. And this balance between realism and optimism, and this paradox that the successes of the golden age, as you're calling it, actually reduce the threat and the visibility of the demand in a way. Even though we're far away from success in addressing burdens, the sense of gain and the sense of diminished threat paradoxically operates against you in trying to keep your agenda front and center in a world that's changing to a much broader set of priorities. Let's open the floor. Yes, please. Please identify yourself. Please offer one intervention, and please be succinct.
Thank you. All right, that's it. No, thank you all very much. And I wanted to thank Dr. Cates for mentioning the word nutrition. And I've heard Dr. Murray and other venues talk about how it's both hard to get the data and hard to get people in the broader health community to focus on nutrition, but it does underlie a lot of the burden of disease. So wondering if any of you could make a comment about that.
Just identify yourself.
Sorry, Peg Willingham with the International Food Policy Research Institute. Thanks.
Others? Over here?
Hello, my name is Kees Kostermans. I'm retired from the World Bank as a public health specialist. Just this morning, I was at the Center for Development, International Development, where the Aid Transparency Index was published, which shows very low transparency rates for many of the donors, our development partners. So my question is, how wide is the confidence interval really of these flows which you presented?
Okay, others? Here and in back, right next to you there, Anya, and then up front.
Hi, Matt Robinson with the Global Health Technologies Coalition. And in an era, as you mentioned, of flat funding, it would be great to hear kind of the role that you see for research and development in global health and potentially getting more for flat funding and achieving more efficiency.
Thank you. Down in front here, Anne, and then we'll come over.
Hi, I'm Ann Penson. I'm at Covington and Burling in their global policy practice, but I spent most of my life at the State Department and Millennium Challenge Corporation and AID, partly working on global health issues. So I wanted to ask a provocative question about how we turn towards a more efficient approach, and that is, do we know who and what the unicorns are out there in our world? Which is to say, do we have concrete evidence of which societies are doing these things best? And can we use that evidence to, as we sort of did at the Millennium Challenge Corporation, to encourage and embarrass other countries into doing things like what Jeff was suggesting, like being more efficient, tapping a broader range of resources, and ensuring that their health outcomes actually match the resources that go into that, which we could then use to sort of reward these countries with private investment and donor investment and so on. I'd be very curious to know whether we know about that and whether we're giving thought to using that as a template.
Thank you. Let's take one more over here, and then we'll come back to our speakers.
Hi, I'm Sunita Sharma. I'm the Director of Health Policy Plus project. I'm with Palladium. My question is, when Chris mentioned that we have these absolute targets now, and it will drive international community to really focus on the poor or make efforts to reach the poor. So I really, and at the same time, if you look at when we set global goals or country level goals, I don't see specific goals for even maternal health or others. Like, are we looking at who we are reaching or where we are reducing maternal deaths, specifically reaching the poor, or anyone at the systems level or service delivery level accountable for achieving those goals? And even if you look at data, resource flow analysis, tracking resources, not necessarily we are looking at who is being benefited, how the resources are flowing. So within that context, how you see it operationalized and how we really make a good effort or do something to reach the poor.
Thank you. Chris, why don't we turn to you first, and then we can hear from Jeff and Jennifer.
Okay, those were a lot of interesting topics. On nutrition, I think we don't track terribly well the nutrition area. I think nutrition really has to be thought of pretty distinctly between undernutrition and what is really a huge issue for everybody outside of the low-income countries, which is the makeup of the national diet and how, cardiogenic or, the effect on cancers particularly. And I think that's a hugely interesting area. It's sort of a policy desert in a way, because people aren't quite grappling with that may be the best strategy for an India, for example, around NCDs. With the confidence intervals, I would say the totals, the very little uncertainty in the totals. I think there's considerable uncertainty in how we code projects to particular focus areas, because some donors give a lot of textual description, the Brits, for example, Global Fund, et cetera, and then there are some for which the descriptions are very limited, and so that makes the allocation. But in general, not huge, to be honest, on the numbers that we show. There's that big unallocated category, and that's sort of a reflection of where we just don't know, and so that would narrow if we had more transparency from some donors. I'm going to roll the last two comments together, which I loved, because they're sort of related in a way, which is, and I think they're I never heard the term unicorns before, but I have a 4.5-year-old, so I've heard about unicorns in a different setting, My Little Pony and something like that. But the idea of performance benchmarks, or what we were actually trying to do 16 years ago in the World Health Report 2000, which is to say, who's doing a great job? I think we can now identify, and you'll see in this year's cycle of the Global Burden of Disease in September, a lot of new work trying to identify performance outliers for health. Saying, given your level of education, of how much your income per capita, and levels of women's empowerment, what do we expect your levels of health should be, and who's beating that benchmark? And the expectation is just the average over the last 35 years. That's really interesting because it focuses, take a place that's often used as an example, Chile. So, people said, oh, this is a great success story. Well, actually, Chile is exactly where it should be given its level on those three factors. It's not really an outlier, except that they've done well in economic growth and education. So, great success there. But they're not a way to get out of the issue about how you can essentially get more progress at lower cost. That's only one half of the equation. The other half is to relate the health system expenditure part. And I think as the quality of data have gotten better, that starts to be feasible to think about relating the financial flows and to these performance benchmarks on the outcome. And that gets really interesting. And that's sort of behind my comment about we need to up our game on understanding the financial flows by area. And the same comment on tracking for the poor is, I think that the next agenda for tracking outcomes, which is already starting to happen, is that we have to stop looking at national numbers and really look at second administrative level results. I say that rather than in the poor directly because it's just much more feasible measurement-wise to do that. We can actually deliver on that collectively of tracking at the district level most outcomes. To track nationally by some split, you can do for some outcomes, but for many you can't. And I also think it becomes more actionable at the sort of level where different types of decisions get made if you can have first and second administrative level outcomes. It's starting to happen. I think it will be sort of our new template for thinking about interventions and outcomes.
Thank you. Jeff?
Yeah, well, let me just pick up on the last point that Chris made. I completely agree with what you just said about the need to look at lower levels in the health system, really understand where the money's being put to use, where the rubber is meeting the road, and whether we are having the outcomes that we like to see in specific populations. But I think one of the big challenges that we still face in global health, and this is partly, it also applies to global development more generally, is that there is a culture among both donors and those who are putting the money to use of being more interested in the level of inputs than they are in the outcomes. And so just think that there are people who are motivated all around the world at all kinds of different institutional contexts to make sure they get the money they need and then put it to use, but there isn't anywhere near the same kind of pressure or interest in measuring what they've actually done with the money and what those outcomes are. So I think that's got to be part of the change. And so some of the questions that talked about performance-based financing and actually looking at outcomes and using that information to decide where you make continued investments, I think that's the way forward, because in an environment in which we'll continue to have fewer resources that are needed based on the best estimates of what has to be done on a range of issues in global health, then there's going to be a premium placed on being able to show that you can put the money to use better and get better outcomes for the money invested. As the UN said a couple of years ago, more health for the money, not just more money for health. I think that'll become increasingly important. The other thing I just wanted to say, on nutrition, Peg, you're absolutely right, and there needs to be more attention. I think Chris's description is a good one of where we are on understanding the policy issues around nutrition. But I would just relate that to the comment I made about thinking of the SDGs as an interacting network. And certainly if we're going to work on women and girls' health, education, nutrition is part of that mix as well. And so I think that helps us because if we can think of ways in which those networks of SDGs can actually help populations do better, then it's easier to figure out how to plan the appropriate interventions and resource them as well. And the last comment I'll make brings together the queries about how do we know who's doing best? And I look forward to the analysis Chris mentioned, because that'll be quite interesting. How do we know we're reaching the poor? And Matt's question about the role for R&D in global health. I mean, these are the kinds of questions that we'll only answer with better investments in R&D on what's people are calling implementation science. And so we actually have lots of studies, thousands of studies, of whether this intervention actually helped people more than that intervention, and what kind of population, and what geographic area, and what kinds of settings, and all the rest. But the challenge is to make sure that all of those studies together add up to more than the sum of the parts, that we actually know what the implications are, and can actually link that with decisions about where to make the investments. And so I've been following with interest, and I'm sure many of you have as well, and many of you are involved in the work, the kind of work that Eric Goosby and his team at the University of California in San Francisco are doing. There's lots of this work going on at Harvard, at the University of Washington, at Duke. I hesitate to mention more, because then those I've left out will feel insulted. So let me just say there's an enormous amount of work in this area going on, and I think that it would be foolish and short-sighted if we didn't continue to invest in R&D for global health, not just in the implementation science side, but also understanding how to come up with better interventions, because we've seen for decades that those kinds of investments do lead to better solutions. And then the question is just how to get those solutions to the people who need them. And that's really what we've been talking about for most of this session.
Thank you, Jen.
Just two quick things. One, also on Matt's question, R&D. The answer is yes, because many of the assumptions and modeling around the future expenses and costs of reaching different goals assume all kinds of efficiencies in sort of the in delivery and in tools that are at intervention. So we need to be able to, are those realistic? Some might be, some might not be. So I think clearly there's a need for that on the R&D side, without a doubt. Secondly, just a quick thing on nutrition, to Peg's question. This is an area that I think more recently there's been a recognition that it's not that it's just not gotten a lot of attention, but the understanding of how it's interconnected really needs to be highlighted. And some work that CSIS is actually doing a lot of work on this, and we've been feeding into it a little bit, looking at what the USG is doing around this, and the USG is trying to, with others, trying to catalog the broader set of activities that contribute to nutrition, and why that's important to do, and how you think about it. So I think there's a push in that direction, but it's still not fully able to account for both the importance and also the full range of activities that are underway. So,
thanks. Let's take another round of questions, comments, right here and over here. Yeah, we've got a couple of folks. Yes, please. We've got a cluster of folks over here. Yes.
Sorry. Hi, Megan Huzzy from Mosaic International. Thank you all for the wonderful panel. The SDGs have a very ambitious goal of leave no one behind, and you all mentioned different things around certain key populations and making sure that they're being reached by health financing. I'm wondering, in terms of certain populations that have been included now in the SDG targets, such as women and girls, rural populations, persons with disabilities, who there might be not as much data on, if there's going to be increasing pushes to disaggregate data by different health funders, and whether that might increase the amount of inclusivity in different funding proposals for mainstream global health projects.
Thank you. Right here.
Thank you. John Simon with Total Impact Capital. Among the areas of potential future financing, there were two that I didn't hear much talk about. One is private investment. Obviously, there's public-private investment through public-private partnerships, but also direct private investment. And the other is peer-to-peer giving, if you will, giving by both corporates and individuals for health outcomes that are pooled through various mechanisms that are now being created, obviously a lot of it through the internet. I'm wondering what role you see both of these sources having in the future of health financing in the developing world.
Thank you. Anya, there are two folks at your table there.
Thank you. Is that okay?
Yeah.
Monica Zaccarelli da Volley. I work at PAHO, Pan American Health Organization, the regional office for WHO. And I wanted just to make a reflection. The flow of funds that you've showed, Joe, are very enlightening when you are involved in the discussion about the global health architecture. I think it's very revealing, where the different forces in that discussion about what is this global health architecture that we are looking to reform, where the forces are. And I would hope the information about the flow of funds would inform that discussion, but the information about the health outcomes we are looking for would also be part of that.
Thank you.
Thank you. Neeraj Mistry, Sabin Vaccine Institute. So I want to get back to the point on efficiency of resource allocation that we have. Because if we look at any 5-year period through the golden age, and I'm referring to that graph, over the past 5 years, despite the flat line or plateau, we're still having the greatest amount of money compared to any 5-year period through the golden age. So the question is, what are we doing with that money and how do we use it more efficiently? So I like the idea of looking at models of public-private partnerships, looking at best practices, what's working, and finding sort of greater efficiency in that area. But is this asking a question of actually revamping our development aid model? Because through the golden age, I could make the case that we were front-loading investments to build a lot of the infrastructure. If that was the case, then we should be now reducing our unit cost per treatment per person because we have front-loaded the infrastructure costs. So part of the question of asking allocative efficiency is often not too comfortable a question is how much money stays in developed countries for development aid as opposed to what actually makes it to the country level. And should we actually address that ratio to think about impact on the ground?
Thank you. Let's take one more and then come back to our speakers. There's a hand right here. Thank you.
Hi, my name is Helena Mingera. Oh, I'm so sorry.
Okay, why don't each of you quickly?
Sure. Sumi Mehta, Global Alliance for Clean Cook Stoves at the UN Foundation. Thank you for the presentations. I just wanted to comment on this real opportunity that we have right now, as you mentioned, with results-based financing, particularly as we're thinking about bringing in other sectors that have a clear direct relevance to health, water, sanitation, energy, for example. But also wanted to note that as we do this, I've really seen so much of an interest in kind of charismatic credits and social impact investing, but I think that the other sectors love the idea of saying that they're making investments that would produce public health impacts, but are not necessarily as careful to define and to demonstrate what those impacts really are. So we have to really make sure that we are actively engaged as a public health, global health community in those discussions as people start to develop these methodologies and make sure that we're actually going to get the return on the investments that are being made.
Thank you. One last, and then we're going to come back to our speakers. Thank you.
Hi, my name is Helena Mangera. I work for the Joint Learning Initiative on Faith and Local Communities. I'm interested in how IHME in the next decades is going to be looking at non-governmental private domestic financing from middle-income countries to other middle and low-income countries. The gentleman over on this side had mentioned technology. Something else that I'm familiar with is religious resourcing. So for example, zakat, which is a pillar of Islam, it says that Muslims should give a portion of their wealth to other poor Muslims. And for example, in Indonesia, $230 million of zakat was raised, and 31% of this is going specifically to health programs to other Indonesians. And so this is, I was looking at the IHME data online for East Asia and Pacific. Private philanthropy is listed as 22 million for the entire region. And so this is far lower than the 70 million just raised by Indonesian Muslims. So I was wondering if religious resourcing is being captured, and if not, is it another area to be looking at?
Thank you. Okay, why don't we come back? We've got a few more minutes left. Want to take a try?
I'm up to the law. So start in sort of quickly in order. I think that there will be a push for more disaggregated data so that we can track in the SDG era both outcomes and resources to different groups, and I certainly hope that will happen. To John Simon's comment on private investment and peer-to-peer giving, one of Joe's slides, which we didn't talk a lot about, is that the total global health sector will rise to $18 trillion. There's a lot of money that will be in health globally. So in some sense, the amount, that whatever gaps that we're talking about are small compared to that total size. And so of course in the 18 trillion, there's a lot of new private investment that's implied in upper middle income, even middle income countries. And I think it's certainly worth spending a lot more attention on that, just given the total volumes of resources. The comment on paying attention to health outcomes as well as dollars in global architecture, I completely agree with that. On the efficiency front, I think that's interesting. If you twin up the efficiency discussion, and I think some of the comments that both Jeff and Jen were making, there are models out there that are, results-based finance models that are trying to encourage more efficiency. I think the most recent one that looks interesting and successful is the Salud Mesoamerica effort, covering 9 countries, I think, in Central America, where relatively small reward payments, but through a very careful, long negotiation process of what are the benchmarks, when do you get paid off, how do you externally review them, seems to have had surprisingly large effects. And so I think there may be models that both address the financing and encourage shifts to be more efficient, and certainly that's one of the routes to think about these financing gaps that deserves a lot of attention. And I assuming I concur with your point that we should be paying attention to the claims made in other investments, because the degree, we always beat ourselves up in global health about data and measurement and stuff, but this is a community that's pretty sophisticated around analysis and data. We have the whole evidence-based medicine, evidence-based health policy movement. The analogs don't exist in some of these other sectors, and so I think that's a really good point. And then lastly, we have not yet tried to track philanthropy within low and middle income countries, but it's certainly something, if we are able to get to the next step of tracking government and household resources by focus area within countries, that would be a logical thing to include.
Jennifer?
I'm more ready to pass, so we can.
Okay. Jeff?
Well, I think Chris covered most of the questions that the last round posed well. I just want to add one point with respect to the last comment about religious funds. I think the answer to your question is that undoubtedly we don't pay enough attention to that. We don't know enough about the flows of those funds. And it's absolutely critical. I just want to mention, I saw a paper a couple of months ago on analyzing who delivers healthcare in about a dozen African countries. And the average for faith-based organizations was 30 to 40% of all healthcare delivery in that set of countries. And I'm sure many of you have experience working in some of those countries, working with faith-based organizations that deliver healthcare. And I just don't think we're capturing the impact that that's having. This comes back to one of the big points I made about the private sector. And I think John Simon, mentioned a couple of other sources of private investment that are important to keep in mind as we try to build out our understanding of private investment in global health. But one could make the same argument for other sources of revenue, like money that flows through faith-based organizations and other remittances. As I mentioned, that comes to about $400 billion a year when you just look at remittances overall. And I think that it comes back to the point, translating that into money devoted to health investment is another question, and it's not a simple question. But at least we should be looking at the broader universe of resources as we think about how to achieve the goals we want to achieve in global health.
Jennifer?
Yeah, actually, this isn't an answer to the questions, but just something I've been thinking as we've been sitting here. No one has, it's probably the first global health discussion I've gone to in a while where no one mentioned Ebola or Zika, which is fine. But the reason I'm mentioning them is because I think that those phenomenon that have occurred in short succession kind of surprised the global community, and in the Ebola case resulted in an injection of funds that no one would have expected, might have changed the landscape a little bit. And so I think that's an uncertainty. We don't know how that might affect both donor engagement, but also countries overall. So that's just something to watch for. And then there's also something that's going to occur that's mentioned in the IHME materials I think will be really important to pay attention to is global fund replenishment. That's going to happen in a few months, and that will be a marker of where donors, public and private, see both their ability to keep funding a very successful vehicle, but also the role of that vehicle going forward. And that will be, I think, critical for all of us to pay attention to.
That's a very nice point to conclude on. I want to thank my colleagues for their help, Anya McDermott, Mackenzie Sumwalt, Sahil Angelo, and others for helping us pull this event together. I want to offer another congratulations to Chris Murray, Joe Dieleman, and the team. Special thanks to Katie Leach-Kemen for her support here. We're very much in your debt. IHME has really sort of raised the bar significantly on what we understand and what we know, and we're in a far better position today than we were 10 years ago. Vastly different position in terms of the data that we do have. There's much more work to do, but I think we owe you all a great note of thanks for what you have achieved in moving us to this point where we can have even this kind of conversation, which really was not as possible much earlier. So please join me in congratulating and thanking our